Hello, it's David Greenspan, and in this installment I'll continue on the complications of twinning. And so we mentioned, I actually made a mistake in the last video. I misspoke. I said that what I meant to say is that monoamniotic, monochorionic twins have a minimal risk of twin-to-twin transfusion. And their greatest risk is, of course, cord entanglement, because there's no dividing membranes. Whereas dimo twins, diamniotic monochorionic twins, are at risk of twin-to-twin transfusion. Now, it's not that mono twins, it's not that monoamniotic monochorionic twins don't have vascular anastomoses. They actually have a lot of anastomoses, but they're counterbalanced, as I'll allude to in a little bit. But the real twin that has a risk of transfusion is the dimo twin, the diamniotic monochorionic twin, and that's the one that the pathologist really has to examine carefully. And it's among the monozygote. It's probably the most common placenta that you'll see in monozygotic twins. So imagine you receive a disc, and here's twin A, or the umbilical cord of twin A, and here's the umbilical cord of twin B. A is marked with 1 cord clamp, and B is marked with 2 cord clamps. And so you note the dividing membranes, and you look at the dividing membranes, and they are consistent with a diamniotic monochorionic, so that there's no chorion in the dividing membrane. So, you know, and you wouldn't know that when you're grossing the placenta, but you could know that it's a thin membrane and it separates off easily. So we'll actually draw the umbilical arteries using shades of blue and the veins in red, because it's sort of the opposite of systemic, like it's just the opposite of systemic circulation, in that the arterial blood is deoxygenated, sort of akin to the pulmonary circulation. So you actually have 2 umbilical arteries, but we'll show only one for the sake of this demonstration. And so you have your arteries of twin A, and then you also have arteries of twin B, and we'll draw them in a slightly different shade of blue. And you notice that there's an equatorial plane. And in some cases you might actually notice contact, direct contact between the 2 arteries, and this suggests an arterial-to-arterial communication. So then each artery should be paired with a vein that then returns blood from the cotyledons to the umbilical cord. And so too, we'll use a slightly different shade of red, and so too for twin B. And for a vein-to-vein anastomosis, so what you would see once again is a vein-to-vein anastomosis, you would see a vein crossing the equator. And here you'd see one of the arteries crossing the equatorial plane. But the other artery-to-artery communications, which we've shown here, are actually the most common, and vein-to-vein are actually the least common. But neither of these are vein-to-vein, but neither of these are particularly devastating, because the pressure and a counter pressure. It's not like one twin pushing blood this way or one twin pushing blood the other way. The pressures basically balance out, and it sort of equilibrates. The real problem would be an arterial to venous anastomosis. And so, in that scenario, the clue to the pathologist is when the pathologist is looking at the equatorial plane, what you'll notice is that as you look at the vessels going toward it, each artery seems to be paired with a vein. Each artery, and remember we showed the artery in blue because they're deoxygenated, is paired with a vein. But here you see just an artery and it doesn't seem to have a vein. Whereas here you see just a vein and it doesn't seem to be paired with an artery. So blood is coming out of this artery, because it's deoxygenated blood from the fetus, and then coming back this way. So the blood is coming in here, but out here, so this twin is functioning as a donor, and this twin is functioning as a recipient. Now, one way you could actually demonstrate it is you could actually inject, like you could either cut the umbilical cord, or you could, even better yet, sort of make a little cut as you're grossing the placenta, you identify the vessel, and then you make a little cut, and then into the artery, let's say, and then you pass in a needle, and you inject in dye, and you inject the dye in, and you pass the dye, and you see the dye comes out here. It comes out to the other twin. If you were to inject dye here and you waited a while, you'd see the dye come back. Or you may just not see the dye at all, like it would just sort of stop. So you could inject the dye and it would stop. But if you actually see the dye go, but if you injected with enough force, you would see it come back like so. But if you actually injected a dye and instead it went to the other twin, and you could confirm that you injected it, for example, into an artery and it came out a vein, and arteries pass over veins, so that helps you morphologically, then you've got an arteriovenous anastomosis. And it passes from the artery of the donor into the vein of the recipient. And so you could imagine that the donor will really be giving blood to the recipient. For this reason, the recipient is more congested and really has organ congestion and volume overloaded. And the donor is anemic and depleted. And so because of that, the recipient twin will get what? Will get polyhydramnios, because of all of the extra volume coming in, whereas the donor twin can get oligohydramnios. It also turns out that the donor twins are usually smaller. All their organs are smaller, and the portion of their placenta might actually be smaller, whereas the recipient twin is actually larger. The recipient twin is at risk of congestive heart failure because of volume overload, whereas the donor twin is at risk of IUGR and also at risk of anemia. And so both twins are at risk, and it's sort of a risky situation. And clinically sometimes they'll actually go in and try and identify the anastomosis and do later coagulation, and one could find an area of infarction. So that's really, so the job of the pathologist first is to the job of the pathologist, because that's sort of what our focus is one, to document the type and extent of anastomosis. So whether it's artery to artery or vein to vein or artery to vein, and estimate the caliber of the offending vessel. And if there's ablation, you would document the ablated vessel and whether there's an infarct or a scar on the underlying parenchyma. And then the next job that the pathologist would have to do, there's another job that the pathologist would have to do, and that is to compare the histological sections in twin A and twin B. Because like you would look at the parenchyma and see if in any way does the parenchyma differ between the two twins. So you would take sections from twin A and sections from twin B. And it turns out, and it's sort of interesting, and I don't really fully understand why, that when you look at the parenchyma of the donor twin, they're edematous and large. So remember the way we were drawing them. So you have a larger stem villi, a lot of intermediate villi, and only a few distal villi. This is your donor. So it's like a hypomature phenotype. It's edematous and enlarged, and there's only minimal vascularity. And whereas if you look at your recipient, it's almost a hypermature phenotype, so you have a lot of terminal villi, and sort of like thinner, smaller, with a lot of terminal villus units. And the other thing that you find is that they're very, very hypervascular, and not surprisingly, the vessels themselves are engorged with blood. But, you know, to be honest with you, when I first learned this, it was quite counterintuitive to me, because it's usually the recipient that is volume overloaded. So it was a little counterintuitive to me that it's actually, although the recipient, you could see the volume engorgement, you see the blood engorgement within the villi, it's actually the donor who looks a little bit edematous. And so that's counterintuitive because the donor is giving volume, but the edematous probably doesn't have to do with excessive volume, but rather has to do with an immature phenotype. And there's something about the biology that gives a donor an immature phenotype. So for a long time, and this is sort of extra points here, for a long time we thought that the vascular problem was primary, and that set up all of these secondary physiological problems. But recently, people began to show that maybe that's not the case. And what people began to look at is asymmetric division of the placental disc, how much goes to A and how much goes to B. An interesting theory started to arise that it's not so much the vascular physiology, the vascular connection that then set up the placental maldevelopment and all these complications and sequelae ensues, and the fact, perhaps they said, perhaps the reason that your donor is smaller and your recipient is larger has to do with a problem of a primary asymmetry. That the first thing that happened, if you go back and think, let's just, we need to find some space here. So if you go back, like to the blastocyst stage, and we said that at some point then the blastocyst formed an outer cell mass and an inner cell mass, and then at some point that'll divide, and it could split, and then maybe you'll get a second one, and that'll sort of represent your twinning. But what if there's an asymmetry in that division, such that one twin gets inherently more, and one twin gets inherently less? So there's an asymmetry. Let's say there's an inherent asymmetry. In that case, the conditions have been set up early. So this is asymmetric. And then maybe the smaller twin, the smaller division, is already set up to become the donor, because we know the donor is smaller, and this inner cell mass is already set up to become the recipient. In other words, the injustice has already been set up early, and the vascular complication is just a late sequelae of an early injustice. And that brings us back full closure to my initial comments about the mythology of twinning and how so much of the mythology of twinning harkens to an early biological injustice. And it resonates quite strongly. And maybe all of these complications and sequelae that we see and try and fight against are the result of an early injustice. And then perhaps all the work we do, our ablation, our treatment of the oligohydramnios, our efforts and energies are meant to rectify this injustice. And in a broader sense, isn't that really the role of us as healers, to rectify the injustice of illnesses and the injustices that we see, and even the injustices of our own biology, the injustice of mixed blessing, the injustice of inequality? Because isn't it true that all children are equally heir to equal abundance and to equal blessing? And so with that, I'll close my comments on the placenta.